will
That
happen, but
was,
then
yeah.
Sushma, there's no point in showing everything at the end. I'm sure madam is
Yeah.
going to use these slides to describe, to discuss and describe. So I think if they are at that time when she's talking about that particular topic, the impact is better.
Sure, whatever you say, no problem. And we'll
Okay,
keep it to the minimal.
Way only we will see. In case there is a streaming issue, then we'll move to the end. If we are
Yeah.
being able to stream properly with each case, then we will
Theek.
share the
No
screen
worries. No
with
worries.
them.
Hi, Amrita.
Good evening, madam. How are you?
Bas, all well.
Good evening, Sushma ma'am.
Hi, Amruta.
Hi.
It's an interesting format, though. I'm feeling like I'm on Viva again. So
Basically, we want to discuss all practical oriented things only, ma'am.
no, it's nice actually, because that's, I mean, it's a discussion between peers. So that is how it should be. And it's like, feel free to ask anything.
Right.
Instagram page mein wo hota hai na. All you want to know about, ask me anything.
So madam, we did have a few topics that we took over the last couple of years in this. All about malaria to a practicing pediatrician, all about dengue to a practicing pediatrician. So all that you want to know in absolute office practice. So it's all the practical points basically covered.
Yeah. And it's good that if it's not didactic, then it's like doesn't be monotonous and nice. Hello, Dr. Chokhani. Good to see you. So as the participants join, we'll be seeing them also.
Yes, ma'am. This is a common Zoom for everyone.
So, madam, if they've kept their video on, otherwise the names, of course, reflect. But
and their sound is all muted.
Yes.
Admin does that.
They will be sharing their questions in the chat box that the moderator will take it from time to time.
Fair.
Sikha, if I miss out on any question in the chat box, please add, and please remind.
Sure, ma'am. We'll wait for a couple of minutes, 2-3 minutes more, and then we will start.
Should we start, sir? Madam, should we start?
I'm okay. Absolutely.
Sushma? Okay, so good evening, everybody. And I welcome you all to this 7th episode of the season 2 of our most popular Webflix series. Last year, as we all know, that was a marathon Webflix over a month. And this year, we've been doing it every monthly on the last Friday, as most of you have been joining. For the ones who have joined today, we would like to tell you that this is a very, very open, closed, I will say an open and a closed room discussion, because it's a 1:1 with a moderator and a specialty expert who is with us sharing the platform today. And today's topic is going to be on pediatric orthopedics. So I think all of us would be convinced that it's not just about the cracked and the broken bones that disturb us, but right from the newborn period, a subtle CTEV to a frank CTEV to a CDH to a DDH to a limb lag to a limb, I think there is a whole lot of problems, some which go into exaggerated physiology and bother us as well as the parents. And when we seek help of the pediatric orthopedic pedicians, and then we have all the pathological conditions that come right up to adolescence when a young person comes in with a little exaggerated scoliosis and we don't know what to do. So I think today with us, we have an expert who is going to get all these doubts clear at the end of this session today. So welcome, Dr. Rujuta Mehta, madam. Madam is a head of the department and a very senior orthopedician who is affiliated at the Bpbi Wadia Hospital for Children. And she's also connected and attached with Jaslok Hospital in South Mumbai. And as I know, at Nanavati Supermax Hospital, as well as the Surya Hospital in the western suburbs. So madam has a vast experience. She has special interests in the club foot and the hip, which I'm told, which is of course one of the topics that a lot of references come, madam, from general pediatricians. And madam has lots of awards and affiliations to her name. I think most of them I was trying to figure out, but the short forms were a little confusing. But I should say that we have a super expert with us today who's going to help us sail through. And to moderate this super expert, we have a super person here with us, Dr. Sushma, who has been our secretary IIP Mumbai for 2 years in the year 2021. She is a very dynamic person who's affiliated as an assistant professor at the Nair Hospital. And she has keen interest in a lot of teaching, clinical teaching as well. So I think she'll be the best person to moderate this as we go from a newborn to an adolescent period. So off to you, Sushma, you can start. And as we always go, all delegates here on the platform are free to put questions in the chat box. And to kick off, of course, Dr. Sushma is going to take a lead and put up the topics as we come across in regular office practice. Related to that, whatever queries are there, you can put up in the chat box and she will take it at that time. Thank you.
Yeah, thank you, Nehal. So, ma'am, let's start.
Sure.
So, as Nehal has already said that the problems starts in utero itself. Okay, so it's congenital and it's developmental and it is acquired due to trauma or infection. So, ma'am, we have this 8-week-old baby coming to a pediatrician for vaccination. And then the pediatrician notices that there is a limb length discrepancy and there is a decreased movements at the hip joint. So he suspects as a developmental dysplasia of a hip, ma'am. So how do you go about this diagnosing of a developmental dysplasia of a hip?
Okay, so I think first of all, thank you very much for giving me this unique platform. And I'm so glad this is going to be more like a tete-a-tete and more like a interaction between peers. So let's talk about these conditions where actually y'all can make all the difference. For those of you know, we have now a published pathway for DDH care pathway in the IAP journal as well as in the orthopedic journals also. And if you want, I can share the link after the lecture where we can go through it. But DDH is a very frequently missed condition. If you are noticing it during a vaccination visit at 8 weeks, it is still not too late. But two important symptoms that you pointed out, one is a limb length discrepancy, which is a very astute observation because it is so subtle at this age. So if you really picked it up, that means it's probably a very high riding dislocation already. And a decreased movements. So decreased movements is one of the red flags. Okay, so that would perhaps more fall into the category of things which mimic a DDH, like septic hip or a spastic hip or some other hip problem because of maybe some sort of a massage or a subtle thigh fracture or something like that. But if you have a limb length discrepancy, if you have accompanying signs of asymmetrical creases, if it's a girl child, if it's an 8-week-old child, then I doubt that you will get both the ortolani and the Barlow maneuvers. But at least if one of them is positive, and if there is also the pathognomonic sign of restricted abduction in flexion. So when you check for abduction, like for example, if these are the hips and this is abduction in extension versus abduction in flexion. So if you're looking at the arc and if this side has almost 70-80 degrees external rotation or abduction, and this one has only 30 or 40, so this difference between the two in unilateral cases, if it's asymmetric and if you have a restriction of abduction in flexion, that is the pathognomonic sign for DDH. Since we spoke about ortolani and Barlow's, I think it's my favorite way to explain it. But for the PGs, it's sometimes these tests are very confusing. When are they most likely positive? They will be positive in the first 2 or 3 months best. In the first month, obviously the best because you still have the maternal hormone relaxin circulating in the baby's body. So they're very easy to elicit. Remember the ortolani as a test of reducibility. So in colloquial language, you can put it as ortolani ya andar ani. Remember it that way. Ortolani. And the Barlow should, in your mind, say bahar lao. So that's a provocative maneuver, which is bringing the hip out. So you're adducting, pushing the hip out, and you're seeing whether it really actually pops out of the acetabular socket or no. But in an ortolani, you're actually reducing. So you're going to flex, 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 abduct and externally, abduct and externally rotate both the hips. So these two maneuvers, as long as they're understood clearly, and if you do them at every first few weeks visit, which is when you're seeing the child much more often, then you would perhaps pick up even earlier than 8 weeks. But even at 8 weeks, it's a good pickup. Then you have to differentiate between the soft signs and the hard signs. So soft signs like asymmetric thigh folds or asymmetric creases would be more or less, they can be fallacious. But a hard sign like a limb length discrepancy or a reducibility positive test, ortolani, and the flexion restriction and abduction, those are definitely diagnostic of DDH. You're on mute, Shrishma.
Sorry for that. So what are the risk factors for developing a DDH?
So like all of us know that breech presentation, female child, multiple pregnancies or history of family history similarly, syndromic associations, other anomalies which may be detected in utero, all those things are risk factors. But one very important risk factor which is not spoken about very often is, especially in the lower grades of dysplasia of the hips, the milder grades, is hip swaddling. And swaddling practices are very, very common all over our country, and they really need to change. And that's why I think the army of pediatricians can actually reduce the incidence of DDH. So if you would allow me to show, I think that's where we can really very clearly show or talk about DDH. Are you seeing my screen here?
Yes, ma'am.
Ma'am, you can make full screen.
Yeah, I'm doing that. It's going to take a little bit time to really load. All right, so till
End
it
of the
loads.
slideshow, actually.
So I've already done that, but it's just taking a while to load up. Anyhow, so if it doesn't work, we'll stop share and we'll do it at the end. What is a common swaddling practice is people swaddling or bundling or tightly wrapping up the child in, I think it's best to stop share because it's not loading up. They tightly wrap, imagine these are the hips of the child, and they hyperextend both the knees, they adduct both the legs, and then they tightly wrap it around. So imagine now what is happening here. If this hip was in abduction, you have slowly pulled it out of the socket here. So this, if it is a mild dysplasia, and if your hip keeps remaining out, the acetabulum then does not get a chance for the femoral head to mold it into shape and make it deeper and deeper. So this is one practice which actually needs to change. So what we are now advocating is hip-safe swaddling. We know the advantages of swaddling are to keep the baby warm, to keep him feel secure, to prevent the SIDS, to kind of have a good mother-child bonding, easy to handle and things like that. But for that, what you can do is you can still wrap the upper half of the body as is, but leave both the legs as free as you can. In fact, most babies will flex at the knee, flex at the hip, and keep kicking outside. That is a very good position for the hip and the acetabulum to develop well in a normal manner. So that we leave those ends wide and loose. And there are 2-3 techniques. I can share the videos also, which you all can then later on share with all the participants. It will simulate the Pavlik harness position, and it will make sure that the hip remains flex, abducted, and externally rotated. And at the same time, you will cover that with a cloth, with a wide cloth, and the child will keep kicking, and the rest of the upper half is still warm. So if you do a hip-safe swaddling, then that you can really prevent or lower the incidence of milder grades of hip dysplasia. The frank dislocations, the syndromic ones, obviously have to be dealt with some sort of an intervention.
Ma'am, you said for the swaddling. So how much is the risk? Means how much percentage is the risk?
So almost 11 to 14% is now being shown. There are many papers on this. But even in not just Indian countries, even Western countries, there are, and African countries, Japanese, a lot of cultures have this practice. And they have shown that as high as 11 to 14% incidence of hip dysplasia because of swaddling practices.
Right.
And which gets detected late then.
So, ma'am, what are the non-surgical options? We have a DDH now, and if it's in a mild to moderate. So what are the non-surgical options, and when is the surgery is necessary?
Yeah. So non-surgical options, the earlier you pick it up, obviously the first line is always going to be non-surgical. In the first 4 to 6 weeks, chances are that you're probably just dealing with the benign congenital subluxation of the newborn. Not congenital, I think we should drop that term totally. There you could get away with just a double diaper technique, which essentially makes sure that both the hips are in wide abduction. And at every change of diaper, you also get a chance to range the hip, again, allowing the femoroacetabular remodeling to happen. If that doesn't work and at 6 weeks on ultrasound, your hip is still dislocated, then you should go ahead and think of doing a Pavlik harness. Now, the Pavlik harness is a very simple cloth device. It has 2 strap pieces. It has a chest piece. The straps of the shoulders go onto the chest piece by Velcro. And similarly, again, straps attach to your thighs. And it ensures that both the hips remain in this flexed, abducted, and knees are also flexed. Yes, what it does is it has to ensure hyperflexion at the hips. If you can see, once this is hyperflexed and abducted, it will remain inside the socket. And 4 to 6 weeks, that has to be maintained. You do ultrasound before, you do ultrasound immediately after applying the Pavlik harness. The groin and that area is kept free. The upper body can be clothed. You can actually do sponging of the child. It's very easy to nurse the child. Yes, you have to make sure that there's no rash or anything. And once applied, and if the Pavlik harness is giving you a good reduction as confirmed on ultrasound, then you just keep it on for 4 to 6 weeks. And then every week you monitor. Every 3 weeks you monitor by a serial sonography. Once you're sure that at the end of 6 weeks also it is stable, then you start weaning off. So from 24 hours, you keep decreasing the duration of the harness. And by the end of 3 months, you have completely given a harness-free stable reduction.
Okay. And when is a surgery is necessary, ma'am?
So that is the next step. If it still remains unreduced on Pavlik harness, if the child is still younger than 6 months to 8 months, you would do what is known as a close reduction under general anesthesia, with or without an adductor tenotomy. So if the adductors are tight and that's why you're getting the restricted abduction in flexion, then you add an adductor tenotomy, which is like a 5-minute minor surgery, and you maintain in the hip spica. Again, every 6 weeks you check that, but that's under anesthesia, but that's a minor anesthesia. And if that also doesn't work, then you have to go ahead with a full open reduction, femoral derotation osteotomy. And later the child comes in later ages, you have to even bring down the volume of the acetabulum. So it's like you get the hip back into the socket. And if it's a very capacious acetabulum, you try and reduce that also. Both come in a press fit.
Yeah. Ma'am, there are questions in a chat box.
Sure, let's take those.
Yeah. Does making the child wear a larger size cloth, reusable diaper, help prevent DDH? As it will keep
larger
the child
size diaper. If it is really leak proof, then probably it may work. But if it's not, then I think it'll just become counterproductive, because for the initial part, it may remain an abduction, but every time I think the parents will get fed up and they'll just go back to the typical cloth diapers. What is a very practical, useful tip that I tell some of the parents who come to me is that they can use sanitary pads or nappy pads, which they get if they are still wanting to use a langot or a cloth. And those are, because if the baby is going to be passing urine every 15-20 minutes, especially neonates, or the infants who are 2 months old, or every half an hour, then those are easier to change, and they probably work a little more economically as well, rather than double diapers.
Yeah,
that could be easily done.
Yeah. So thank you, ma'am. There is a comment that swaddling is a more or less universally done, but I don't see dysplasia, means I must be missing lots of them. So I really do not know. It's an iPhone, so no name. And Chokhani sir wants to know that can we use USG even in an older infant to diagnose DDH, or should we use X-ray?
Yeah, so beyond 4 to 6 months of age, X-rays are more useful. So we'll go from back to front. But any child less than 6 months, ideally sonography still can be very much used. Yeah, you tend to overdiagnose with sonography if you're using it in the first month of life. But then you monitor the hip dysplasia and you see whether the type of hip dysplasia is coming down slowly. So if it was a 4 to start with, is it coming down to grade 2? And regarding the oversized diaper or missing the DDH in the swaddling practice, so see, for a pediatric orthopedic surgeon, it is a large volume which will come referred to us because it will come from many places. But for a routine pediatric practice, it may be that 1 or 2 that you see out of 100, which may be having a mild grade of dysplasia. So there is a real but genuine chance of missing that dysplasia, which would eventually show up at 4 or 5 years of age because the acetabulum has just not remodeled and the slight subluxation then starts. So world over now, people are switching over to safe hip swaddling. So you can continue the swaddling, but you need to do a hip safe swaddling where the legs should not be tightly adducted and overlapped on each other, and knees should not be in extension. That certainly should be done.
Yeah. So till what age can we do a USG to diagnose DDH, ma'am?
6 months, like I said, up to 6 months, it still can be used. Beyond that is X-ray.
Yeah. Ma'am, what are the long-term consequences if you have not treated a DDH earlier?
Yeah, very, very good question. The whole idea behind it's not that DDH children don't walk. They will walk with a lurch if it's bilateral, or they'll walk with a limp if it's unilateral. It's essentially a painless limp, so they will always walk. So we don't treat them for the sake of whether they will walk or no. We treat them so that they do not develop early osteoarthritis. The best of arthroplasty surgeons have said that the only replacement to a baby's hip is the baby's hip itself. You cannot do joint replacement that young. So it is very, very imperative, because once it is out of the socket for a long time, it gets malformed. You don't have the lovely round head, and you don't have the acetabular cup fitting onto it like a press fit. So the more you leave it out, the more dysmorphic it gets, and the more difficult it gets as a surgeon, even if you know how to do a hip to treat it surgically. Your outcomes start deteriorating. So the best treatment is in the first year of life, and that's why the DDH care pathway, which POSI and IAP and Neonatology Forum and everybody put together, has timed it with the vaccination schedules. So you do your clinical examination, you do your Ortolani Barlow, you do the other tests. If not, there's a suspicion, send for USG. If it's an older child, send for X-ray and do that at every vaccination schedule. I'm sure y'all can train your PGs to just add 2 minutes of a clinical examination to it. And like it is done in all neonatology wards, it is always checked. If you do it to your vaccination schedule also, I'm sure over a period of 5 to 10 years, we can bring down the incidence.
Yeah, thank you so much, ma'am. But just wanted to know, ma'am, your experience dealing with a DDH, positive also and a negative also.
So positive is, I think, the thrill of getting that click of reduction on table, or seeing the child who comes back to you with a successful Pavlik harness. It is unparalleled. When we have seen those sonographies, which we've repeated, like we picked it up at 4 weeks in a child. I remember this was a child in Jaslok, and the parents were so angry when they had come because they wanted to sue the obstetrician, thinking that a dislocation can only be caused because of force. And so a lot of calming down had to be done. And after that, when we put in a Pavlik harness, everything got reduced. And at 3 months, when we repeated the sonography, you could not make out the difference between both the femoral heads. So the whole paradigm shift of early treatment, it is so rewarding and so natural. Those positive cases, then when those children walk, the parents send you videos and they're so happy, that because that's one major worry for them. And the negative is, I think every surgery, the surgeon's knife it's not a toy. It has to be wielded very, very carefully. Every surgeon worth his or her salt will have had complications. And believe you me, I have seen things like sciatic nerve palsy. I've seen things like accidental injury to the femoral artery during dissection. I've seen children who were running around with hip dislocations, DDH, who underwent late surgery and then the hips got stiff and painful. So all of these can happen, and therefore, because a treatment exists even surgically, and parents tend to go into denial as that they don't want it, or they go doctor shopping, that is when I think the pediatrician's family bonding and the image comes in very handy, that you have to counsel them for early treatment.
Yeah. So, ma'am, Dr. Jagruti she was talking about a super bottoms. So,
I've never seen a super bottom, so I don't know.
Same here. Even I don't know.
I would have to try one myself on some child.
Okay, ma'am. So, just moving on, ma'am.
Sure.
So, we have another common problem, that is a talipes equinovarus, ma'am.
Yeah.
So, then how does it gets diagnosed in a newborns?
So nowadays, I think let's go a little backwards. We can even pick them up antenatally, and which is happening rampantly.
Yes.
There's a huge spectrum in clubfoot, right from simple postural clubfoot to metatarsus adductus to idiopathic but supple CTV to rigid syndromic CTV and with associations. If they're picked up antenatally, all you do is counseling. You tell them there's a treatable anomaly. You look for associated CHK, that is congenital hyperextension of the knee. You look for decreased fetal movements, which may alert you to the possibility of arthrogryposis multiplex congenita, and you look for other major anomalies. If those are not there, spina bifida, etc. is not there, you should encourage the parents to go ahead and allow the pregnancy to reach full term. And you can start treatment as early as 4th or 7th day. When we were training as residents, we used to do plastering under GA after 3 months of age. Versus that, ever since the Ponseti treatment came in the early 90s, Now it is a OPD basis treatment. If you have a nice, calm, relaxed child, first 4 to 5 days after the feeding schedule is established, the weight gain is started, the physiological jaundice is out of the way, then you start OPD basis plastering. If you've kept your plasters ready, if you have a nice, well-fed, quiet child, we can finish one leg plaster in literally 10 minutes. And it is so easy. It is removed next week on the same day by just immersing a plaster in water. It's a very gentle maneuvering that we do of a very, very complex deformity because it's all based on the kinematics of the foot. So you imagine this is let me show it to you this way. This is the club foot. So first stage, you simply raise the cavus and bring the forefoot in alignment with the midfoot. Next plaster, you start bringing it into neutral. Third plaster, you start abducting gradually. When from a varus, it completely goes out into a valgus, then the only structure that remains is your tendoachilles, which you release by tenotomy under local, and the whole anomaly gets corrected, say something like 5 to 7 OPD basis plasters. And it is so much cheaper. It is so much easier. It is so much more gentle on the child's foot. Even rigid CTEVs, even syndromic CTEVs, the first line is always the Ponseti technique, after which they go into a brace or a foot abduction brace, which keeps them both in this abducted and dorsiflex position. For the first 3 months, it's a rigid brace where like 22 out of 24 hours. After that, as the child's milestones start progressing, when the child starts turning prone, sitting up, going on all fours, that time it's only a nighttime and nap time bracing till 4 years of age. If this is followed religiously, then most of the CTVs don't even recur.
Okay. Ma'am, you mentioned about Ponseti method. So how effective it is? Means it's
90 to 96% corrections. I mean, one of the most successful treatments in pediatric orthopedics. So it is very, very successful. The surgery level also is reduced, right from a full-blown posterior medial release or a big surgery. Now it's like a 10-minute one-stitch operation, which is done under local. So it's a very, very successful technique, and you have to really see some of the results. I think for the streaming quality, we had some issues when the first time I did a slide share, but I promise I'll show you all these pictures at the end of the
yes,
discussion.
Yeah. Ma'am, are there any complications or side effects of using a brace for clubfoot?
So it's not, I wouldn't call it really a complication or a side effect. It's more of compliance issues. So if it's too tight a brace, or if the parents are really tying the braces too tight, or the child has skin issues, then they can get some sores. But those can be all minimized by using a lot of emollients, lotions, wearing it over cotton socks, or using some cotton padding at some pressure points.
Yes, ma'am. Ma'am, does the clubfoot has any genetic origin to it? Or
Yeah,
what causes?
many of the syndromic ones, many of the ones with arthrogryposis, many of the ones with spina bifida, neural tube defects, those would have. It's a huge spectrum, right from supple postural to this thing.
Yeah.
Syndromic.
Yeah. And then, ma'am, in difficult deliveries, like a transverse lie or something, and we get in a baby with the arm being adducted, like we suspect a brachial plexus injury. So you said you have you are interested in
One
that
of my
also.
large interests is OBPP.
Yes.
Yes. So before we move on to OBPP, there's I think already a question.
What should we do for babies with a flexible club foot as it in not rigid?
Okay, so first you have to do counseling for them, saying that this is a perfectly treatable postural clubfoot, which may be due to just less space in utero or multiple pregnancies. They need to keep, mother herself can be taught that with every breastfeed, from adduction, just gently keep on everting the foot and hold it there for 5 seconds. In addition, they can stroke the peroneals. They can keep on doing a dorsiflexion. And within the first 6 weeks itself, you will see that there is a marked improvement. If despite all this, there is still a forefoot abduction that persists, then you could ask them to go into AFOs temporarily or dorsals. There are splints which are made easily. Or when the child starts walking, they can use reverse shoes. A lot of children anyway love to put the right shoe in the left and the left shoe in the right. So you can, it's a simple trick, but you can ask them to do that as a game. And that is what also helps, because when you use the lateral border, which is straight on the medial instead, it acts as a AFO, or it acts as a block to the forefoot adduction. So that could be done.
Yeah, ma'am. The brachial
Okay.
plexus.
Let's come back to the OBPP. Yeah, okay. So first of all, the term OBPP now is almost given up. You have to say Bpbi, that is birth brachial plexus paralysis. Or brachial plexus birth injury, Bpbi. That's the correct terminology now. 70 to 80% of them are neuropraxias. But if it has been a difficult labor or difficult C-section where there was a rush, or there was some sort of a fetal distress, remember that even in those split seconds, you can have a very severe injury where if the neck was just not coming out and you were unable to deliver it, then you can have a global or a pan plexus, right from the C5 nerve root to the T1 nerve root can get totally avulsed. So the dictum in Bpbi now is that first 4 to 6 weeks, counsel them, give them gentle, active exercises by the mother only. Start the mother on Resner or Meganeuron or some, high dose of B1, B6, B12. And no physiotherapy, no splinting in the first 6 weeks. Even no EMG in the first 6 weeks. If it is just a neuropraxia, you give time for the Valerian degeneration to get completed and then new impulses to start recovering, you will see some movement improving. So something which was flaccid now starts showing you signs of recovery. Keep following that motor march. If at 6 or 8 weeks you feel that there is not adequate recovery, that's the time when you do a EMG, so that you can get a clear idea about what lesion it is. Is it upper plexus, just C5-6? Is it upper and middle plexus, C5-6-7? Or is it C5 to T1? If there is a Horner's sign, one eyelid not opening enough, or a clavicular fracture or a humeral fracture associated with the Bpbi, then it is most likely a very severe trauma, and chances of avulsions and pseudomeningoceles in the spine are very likely. So if that picture remains unchanged at the end of 3 months, the child is showing absolutely no motor recovery, do not waste time. Consult a good brachial plexus neurosurgeon. I mean, not a neurosurgeon, I would say a plastic surgeon. They are the ones who really deal with the brachial plexus, because that will need not just intercostal nerve grafting or sural nerve grafting. It may actually need to plug in right into the opposite C7. So it's a very complex surgery which may be needed, because only then the paralyzed segment will start getting innervation right from here and reach up to the fine fingertips at the end of 1.5 years. If, as the brachial plexus examination is going on, if the baby keeps showing you recovery and if shows you good spontaneous anti-gravity biceps at the end of 3 months, the baby is going to recover. So have no fears on that. Now, will it recover partially or fully? That is going to be the big question. So between 3 months to 6 months, you will keep following them, and you will keep on doing serial EMGs at 6 weeks and clinical examination also at 6 weeks. If the nerve graph or the neural recovery is steadily progressing upwards, then nothing to be done. Go on teaching them exercises so that the joints don't get deformed. But if you have only internal rotator recovery and external rotator is not coming, then the shoulder joint will get deformed as early as 6 to 9 months. So that is where the physiotherapy should start. Either the mother should do it herself, or you get in a good therapist to prevent the shoulder contraction and the wrist flexion contracture. So those things, if not treated in time, then they invite surgeries. Sometimes they recover partially, they don't recover fully. So at the end of 9 months, the child does bye-bye to you. Absolutely nothing to worry. This is a near full recovery of the brachial plexus. But if that is not happening, then you can use Botox when you have co-contraction. It's like a cross connection in a telephone call. I want to give a recovery nerve to my biceps. But in addition, my neurons have also gone to the triceps. So every time I want to flex the agonist, I'm also innervating the antagonist. So the child just keeps doing that with the help of the pectoral, and the triceps keeps overpowering the biceps. If that is happening, then I have to temporarily block the triceps. Same way the subscapularis. All these muscles can be Botox because Botox is a temporary paralysis of the too strong or the overpowerful muscles. Meanwhile, the plexus will continue to recover and all the range will get restored. But if despite the Botox, the contracture is persisting, then better to release them early rather than later. There are many surgeries in brachial plexus, but I think let's not cover that. I think this was more of an algorithm or an approach to Bpbi, which I thought would be more useful for you all. But if you still have questions, please do ask.
Yeah. So, ma'am, regarding a brachial plexus, we'll take one, and there is one more for the clubfoot.
Clubfoot, sure.
So, yeah. So, what is the role of a Faradic stimulation in brachial plexus injury?
So, in a recovering plexus, it will help in maintaining the biofeedback. It will certainly help in the cortical recognition of that particular muscle. But essentially, if the plexus is either recovering by itself or it has to be given a plug point to get reinnervated from. It is not that the stimulation is actually causing the recovery. It is natural recovery which is happening. And because there's good biofeedback, the child learns to be doing bimanual function. Otherwise, sometimes the extremity goes into a hemi-neglect, that the child adapts and starts using only the other hand. But yeah, physios are very fond of Faradic stimulation.
Yes,
so
yes,
there's no harm done. So we can
Yeah.
go ahead with that, not a problem.
Yeah, because
But
all
preferably 3 months or 4 months and onwards, not before that.
Yes, ma'am. So regarding the clubfoot, ma'am, we are going back. How do we decide if it is a postural clubfoot or a clubfoot requiring a Ponseti technique in early newborn period?
Very good question. So postural clubfoot essentially will be completely supple and correctable immediately at birth. So if you're examining the clubfoot, this is your, should I show it this way? This way is better. Yeah, if this entire complex is completely supple and correctable on day 1, you're dealing with a postural clubfoot. In addition, there are some signs. It's known as a Pirani score. Do you have a deep medial crease? Do you have a rigid equinus? Do you have a curved lateral border? So there are 6 kind of points which are measured on the Pirani score. If the Pirani score is high, then surely it's going to require heel varus and all those things. So it's going to require plastering, which you can start as early as day 4 or day 7.
Yeah. Ma'am, let's move on now.
Sure.
So, ma'am, the baby had an ICU admission, okay, and now he comes at 1.5 months for a follow-up. But there he gets a knee swelling, one knee swelling, one ankle swelling, one elbow swelling, refusal of a feed, very toxic and febrile child. So here we suspect a septic arthritis, ma'am. So how does one go about it?
Yeah, so septic arthritis is a very common problem in India, especially with NICU graduates, or even in the NICU, because they may not have the immune response fully loaded. They might be more susceptible. The superficial joints like the knee or the elbow, you will see an effusion. You will see non-usage of the extremity. You will see a tender, tense swelling. But the hip joint, very often missed because it's a deep-seated joint. So there you can do sonography, especially if there is crying during the change of diapers, or just when you hang the child up, you do the suspension test and he's just kicking only with one leg and keeping the other one flexed and not bringing the hip leg down, then suspect septic hip and ask for a sonography. Earlier stages, say in the first 24 to 48 hours, you may not get a full-blown effusion. But if you're doing a Doppler if you ask for with a Doppler along with the grayscale sonography, then they can pick up high peak systolic velocities. If that is there, then that means there is hyperemia in that capsule and septic arthritis is surely setting in. For the other joints, which you can see superficially, sonography is still the method of choice. You can do your counts, of course, start your antibiotic cover after you have done a drainage. And as the job of the drainage really is to debulk and get all the pus out, plus you can send that pus for culture sensitivity and start appropriate antibiotics. And then it's a hand-in-hand treatment, that surgical drainage. If the child was a little late and the hip has already started dislocating because of the septic arthritis, then we apply the Pavlik harness. And we give antibiotics for about 4 to 6 weeks, about 10 to 12 days of IV and half an hour of, about 4 weeks of oral. That is what we prefer to do.
And such some bigger child, ma'am, 1.5 year old with an osteomyelitis, like they come.
Again, you would have to drain. The investigation of choice will be sonography. To know the extent of the infection, you may do MRI, but of course, we like to avoid MRI for children unless you are suspecting a skip lesion, because MRI will mean additional anesthesia. Or you are, there's a half and half sort of a lesion where IV antibiotics have already given, so the presentation is unclear, and you want to see how much the whole shaft, whether the whole shaft of the femur is involved, or the extent, or there are 2, 3 multiple joints involved, multiple bones involved, then it's better to do an MRI so that you know which all areas will need drainage. And then again, as we go back to it, culture-specific antibiotics, 8 to 12 days of IV, and another 4 weeks of oral. And splinting. All septic arthritic and osteomyelitic joints and bones will need protection either with a plaster or the appropriate splint to prevent sequelae.
Ma'am, we do get a report in a sonography saying that there is a synovial thickening. There is some effusion and there is a synovial thickening. So what is your take on taking that synovial biopsy?
So whenever we go in, we always do it under GA, and I do not prefer aspiration in clinics and all that unless the child is so toxic that you simply cannot, is already in a full-blown sepsis and even the bleeding parameters are deranged. Only then you can do an aspiration just for taking out some pus and sending for culture. But by and large, you do it under GA. So since you are doing it under GA and you are draining, you will take a little bit of the synovium and send it along for histopath. More for completeness, but it's not that you're suspecting any other pathology. Yeah, if it is a 1.5-year-old child, then it has value in terms of being able to differentiate it from tuberculosis, because that is again coming back with a vengeance. So biopsy every culture every biopsy. Once in a while, there might be a surprise where you have the triad of fever, joint effusion, and anemia. And such times we have seen that it's hematological malignancies, which can present, especially in a 1.5 or 2-year-old child. This may be the first presentation of that. So if you maintain the dictum of culture every biopsy and biopsy every culture, you're unlikely to miss those.
Yeah, point is well taken, ma'am. Now, we do have some to and fro with us, orthopedics and pediatrics, bow legs and knock knees.
Yeah, that's the favorite, I think, of
yes,
and biggest worry of most mothers, especially when neighbors and well-meaning aunts and all will come and say, "Tera bachche ka paun teda ho raha hai."
Exactly, ma'am. So, ma'am, what is a normal age range for the natural resolution of a bow legs and a knock?
So, from between 1.5 years to 4, you expect that the child will have physiological bow legs, which will go into either a rectus or a valgus first and then autocorrect. So up to 4, if it's a steadily decreasing deformity, non-progressive deformity, you don't worry. If there are no associated syndromic features, if there are no asymmetrical features, and if there are no other, history-wise, any other reason to suspect one of the different forms of rickets, then wait and watch, and no stigmata, no other, your biochemistry is normal. You can take a simple X-ray of the wrist rather than expecting a 1.5 or 2-year-old baby to stand still for an X-ray of PBH up to ankle. Just pin them down and take one X-ray of the wrist. If that is not showing cupping, spraying, flaying, all those signs, most likely it's physiological. Counsel the parents, and they can do some massages and exercises, but those don't help. What helps is getting growth and getting height. So up to 4, you would not worry. Yeah, if it is a genu valgum or a knock knees presenting before 3 to 4 years of age, you must look for syndromic features. You must look for things like, early Ellis-Van-Creveld or some of the other associations, or a mucopolysaccharidosis, or, those kind of things. So then the general examination will become very important. Then it's unlikely to be physiological. Asymmetrical bow legs or knock knees, accompanied with other features like short stature and coarse facies and things like that, or syndromic features, or non-responsive to calcium and vitamin D supplements. Those kind of knock knees, bow legs certainly need more investigation.
So what are the indications for a surgery, ma'am, in these cases?
There are multitudes of surgeries actually that you can offer. If it is a simple idiopathic or a simple post-rachitic bow legs or knock knees, the younger the child is, you can offer growth modulation. So what is growth modulation? Growth modulation is a temporary stapling or a plating, which is essentially reversible of only the epiphysis on the overgrowing side. We do that so that temporarily you have halted the growth there, while the biochemistry is in control and while the other side of that physis is still open to expand as the child keeps slowly growing. So it's a slow correction. The day you do the surgery, the child will look the same. After 3 months, child will look the same. 4, 6, 8, 9 months down the line, you see a gradual improvement in that correction. Most of the times, by the end of 1.5, 2 years, the whole deformity, even as large as like a complete O-shaped deformity also, would have fully corrected. And you simply go in and pull out the plates, which is again a small surgery. If there is accompanied by sort of a syndromic association or some rotational elements, then you may have to add a small osteotomy with a temporary fixation there. But if it's a child nearing puberty, if it's a child who is very syndromic in nature, then better to couple that with osteotomy and large fixations so that you get the correction at the same go. Now, whether you do it with a plate or with a 6-axis fixator or Elizar, there are many apparatuses available. That will depend on how severe and how syndromic the child is. But growth modulation is a big boon. I think over the years, it has really changed the face of how we treat bow legs and knock knees. Post-COVID, we are seeing a huge surge in the amount of knock knees that we are seeing, especially in adolescent girls. And those are all ending up with big surgeries, but those deformities also get corrected very beautifully and they go on to do very well. We'll take it in some of the slides. We'll show it to you.
Yeah. If I may ask you, you said post-COVID, there is a surge. So why do you think so? Means what?
Because the children were totally in-house.
Achha, okay.
See,
okay.
there was lockdown, there was online schooling.
Yeah.
So although the parents came out to work, they were still.
Yes.
And if you see the urban phenomenon, I mean, in general, the way our children are growing up now, they are either playing around in the house with their PlayStations, or they are going on play dates to somebody else's house, which very often those play dates are either in a mall or at some other exotic locale. The way we grew up just playing kho and langdi and all that in broad sunlight, that actually is really not happening. Yeah. So the more of that that we see, and this urban phenomenon, we are seeing a huge surge in the knock knees that we see nowadays.
Yeah. Ma'am, the next very common topic is in-toeing and out-toeing.
Yeah.
So what are the causes of this, ma'am?
So in-toeing is a very benign condition if there is no other syndromic association there. Most of the times it is because of the W sitting and a phenomenon known as increased anteversion of the femur. Basically, what it means is that the femur bone is facing a little more towards the front of the body. And hence, as a compensation, the child is pigeon-toed or is placing the foot. What you're seeing is like the tip of the iceberg, like where you're noticing it in the foot, but the actual problem is with the hip rotation. And the more they do W sitting, the tighter the internal rotators get, and it is supposed to burn out over a period of time. Again, it's one of those physiological conditions. By the age of 7, it should reverse. If not, then it may need surgical correction.
Ma'am, so what are the treatment options? Surgical correction, can you just tell us in a brief?
So surgical correction, I mean, you do derotation osteotomies at the tibia or the femur. But by and large, you shouldn't really need it unless there's a syndromic association or you have a condition known as miserable malalignment. But we won't talk about it today. I think that will be too much for
Yeah, yes, ma'am.
the whole
So
thing.
next common is, ma'am, flat feet.
Hmm.
So yeah, pace planners. So ma'am, at what age should a flat foot be a concern for a children?
So if the pest planus is not supple, if it's accompanied right in the beginning also with a pathology like cerebral palsy or some syndrome, or it's part of a DMD or something like that, then certainly it is a cause of concern. But otherwise, the common supple, flexible pest planus, which a lot of children come with, that should be a concern only if it's worsening after the age of 3, 4, or 5. And the look is really bad. It's accompanied by one of the hyperlaxity syndromes. It is, you have a severe collapse of the arch. And if it's causing a gross instability, there is a heel valgus, then it is cause for concern. And you should first try exercises using SMOs and shoe inserts. If it doesn't work, then there are good osteotomies after the age of 8, which can be done.
Ma'am, can they participate in sports and normal
Yes,
physical
absolutely. They can
activities?
live a completely normal life. They just need to have their threshold of, say, how much speed they will use or how fast they get tired. That is something that they have to learn to control. And the best thing to do about is the basic stretches of the tendo Achilles and anti-gravity muscles strengthening, plus making that as a daily routine, say morning, evening, so that they don't get fatigue pains, because by and large the pains that they get are fatigue pains. So
Right.
controlling that and good physio and isometrics really helps.
Yeah. So then one of the comment is that they usually does not do good in sports. Is it true?
No, I mean, doesn't hold fully true unless the parents are over ambitious, but they may get tired faster as compared to the other children. And that they can get trained into becoming better athletes. So they just need to put in a little extra effort, but they can do well. I mean, frequent falls and all those things are just, attributed to in-toeing and knock knees. And very often you'll find that if it's a hyperlax child and he's in-toed plus flat-footed, to compensate that, the femurs tend to have a mild physiological knock knee. So it's like a triad. All three things would be there. So then you work on the whole body dynamics. You work on hip external rotation. You work on inverters of the foot and the isometric stretches. And gradually they will improve over a period of time.
Ma'am, can a flat foot be a cause of a knee pain?
Not always, unless you've really not done anything about it. The child is really obese, or the child has a pathological form of flat foot, like a navicular, accessory navicular, or a tarsal coalition, or a fibulocalcaneal impingement because of very severe heel valgus, then those things can cause knee pain as a mechanical pain over a period of time.
Wearing a insoles works for a flat feet?
So the insole is a very good question. The insoles that you get commonly off the shelf or from Amazon and all, they are just cushions. They basically simulate the mechanics of the arch. If you truly want a good orthotic for a flat foot, then the best thing to do is an SMO. So the SMO, it's a supramalleolar orthosis. Imagine this is your ankle joint, this is your flat foot, and this is your subtalar and the ankle joint. So the SMO goes all around and it doesn't allow the heel to come out in valgus. That is what is actually needed for very severe flexible pest planners.
Yeah, ma'am. Actually, we can just go and on, but you have some slides to show us.
Yeah, I think
So,
relevant to
yeah.
what we had discussed.
Yes,
So let's
yes.
go into that. Tell me when you start seeing, right?
Yeah.
Okay, I think best is to go from the top so that we cover everything. Whoa. Every time I say
I think when you
screen
go to
share,
slideshow, it gets
yeah, it gets,
by
so
the
then we'll just keep it on this mode.
yes, ma'am.
Is
You
that
can go
okay?
to the above one.
Okay. So are you all seeing this well?
Yes, ma'am.
Okay.
Yes.
So this is a PBH AP view, that is pelvis with both hips AP view in a 3-month-old child. And this is the frog leg lateral. So if you pay attention here, this entire part is cartilaginous. So here you're just imagining where the femoral head is. So if you look at this, you have to draw like these Perkins line, Hilgenreiner's line, and then you'll realize that, oh, this femoral head is actually out when you thought this one was. So it's not this hip which is out, it's this hip which is out. So since baby's hips are cartilaginous, therefore the investigation of choice is ultrasonography before 6 months of age. Okay, then this is what we were talking about. Is swaddling really a risk factor? Yes, it is. This would be the hip of the child. This is the child's leg. Adducted, hyperextended, and turned over to the other side. Instead, what we recommend is this kind of a hip swaddling. Now, this, unfortunately, the animations were meant to be in full screen, but this is the position that the child will be like in a Pavlik harness inside. So this is the knee of the child, knee joint, flexed, abducted, and this is the leg, tibia. And they're free to kick here. It's still equally nicely well bundled up on the upper half. And this is a very good way of maintaining the swaddling. Then this was your typical Pavlik harness. Just cloth and Velcro straps. Hip is reduced, hyperflexion, knee is in flexion at 90 degrees, and the foot is at 90 degrees. And like we spoke about, this is the safe corridor. 40 degrees abduction, 60 degrees flexion there in the Pavlik harness. This was the child I was talking to you about. Managed in a harness at 6 weeks. This was the sonography at the beginning. If you see, this is the acetabular lining. That's the hip joint globe. And that's the, muscles, how much out it was. And now you see the acetabular lining and the cup. This is the cartilaginous roof. This is fitting nicely well. And this is the other side. You couldn't really make out the difference between the two sides. This is our club foot versus a metatarsus adductus. A postural CTV will be even more supple. Metatarsus adductus, the deformity is only in the forefoot. The midfoot and the hindfoot are normal. Whereas in a club foot, you have it's a 3 apices. That's your forefoot, that's your deep medial crease, that's your heel varus, that's your rigid equinus. This really looks like a bean-shaped or a golf club. So that's why it's known as a club foot. And this is how Ponseti works. This is the bone model. This is from the front. This is from behind. This heel is in varus and this forefoot is in metatarsus. So see the front here. This is the first plaster. Second plaster in neutral. Third plaster bringing out an abduction, gradual abduction and full after the tenotomy. And corresponding to this, see what is happening at the forefoot. While this is moving out, cavus is getting corrected and going out into abduction. The heel also is moving from varus to valgus alignment. So each plaster corrects one component of the deformity. And that's to show you the full thing in actual clinical practice, full-blown clubfoot. First 2 plasters, again, full-blown clubfoot, brought out till the abduction is once you have the lateral border straight, then you do a tenotomy and bring the dorsiflexion. This can be easily done in a clinic also. And that's the kind of result. The child can squat fully, run around, jump, do everything. This is the genu varum, like we said. This is the syndromic child. So intercondylar, that's what we forgot to speak about. The intercondylar distances is important in a genu varum. It is more as a guide to decreasing magnitude of the deformity. And in the valgum, you look at intermalleolar distance. Of course, when you're doing both these, it's important to see where the patella is. So make sure that the patella is facing forward and not outwards like in this picture. That will give you a good guide. And this is how growth modulation works. This plate is applied on the side which is overgrowing. So this is a genu varum. We've put plates on the femur and the tibia, and we've kept this part of the physis open. This is diagrammatically being shown here. As the child grows, it corrects. And that's a clinical example. She had a very, very big deformity. So if we had done osteotomies, we would have to remove bony wedges at 3 places here. A simple 8 plate over a period of time, she went on to correct fully 24 months post-operative, just with one small surgery. And this, we didn't really discuss this, so let's not go into it because anyway, scoliosis is not really my forte. So we'll stop share here and any other questions? If
Yeah, ma'am. I'll just quickly take 2 questions, ma'am. Is it okay? Yeah.
Yeah, sure.
So vertical talus also causes a severe foot pain. So your take on that?
Untreated vertical talus, yes, will cause a severe foot pain. Vertical talus is a much more difficult deformity to correct as compared to a clubfoot. There are minimally invasive techniques or some plasterings which are done as early as possible if you can. But it will invariably lead a little more surgery. The sooner you start, the better. At least before 4 months of age, if we get the reference, then we can go ahead and by 1 year of age, if we've been able to operate, we can correct this deformity fully.
Ma'am, and can you please tell us about the management of a congenital or infantile torticollis?
Yeah, again, a very common condition. If it's a congenital torticollis and you've ruled out all other, causes, there's no ophthal cause, there's no other C1, C2 and all that. Once that is out of the way, then you can do very simple gliding movements. So for those of you who are familiar with Bharatanatyam, there is this side-to-side movement of the neck, which is exactly what we do. We keep this steady. And right from the C1, C2, we translate the skull over the vertebral column very minimally. And that's what the trained physios will also do. In addition, you teach them lateral flexion, side bending, all those things. But the main correction is caused by doing the C1, C2 gliding movements. Up to 1.5, 2 years of age, if you get daily supervised this kind of physiotherapy, then excellent results are there. I've hardly had to operate any of those patients who were regular with therapy. But the ones who fall out of therapy and all, when they come, then it's better to operate them before 3 years of age, because otherwise the hemifacial atrophy, because the neck is just tilted on one side, that becomes very, very prominent.
Yeah. So thank you so much, ma'am. It's almost 10:38. And still my many questions as we have shared with you remain. But I think we need to stop here.
No
May I
problem.
request Nehal to take over?
Yeah,
Nehal
I'm
or
there.
Sikha? Yeah.
Feel free to
Yes.
send keep sending these questions, and I can happily answer them and send it to you for the WhatsApp group. Not a
Yeah,
problem.
thank you so much. That's very nice of you, ma'am.
Thank you so much,
Sikha.
ma'am. I think it was a wonderful session, and I think we need one more session to cover so much topic
Yes.
because orthopedic issues in pediatric population, we all know it's huge. And you have been very crisp and clear in covering topics which are so important. Newborn issues to DDH, clubfoot, brachial plexus injury, and even infections like osteomyelitis. So everything was very, very well covered. And as always, you were awesome to listen to. So thank you so much, ma'am, for this. And also thank you, Sushma, ma'am, so covering and moderating it so well. I think ma'am took very relevant topics and very relevant questions, which was very important for an OPD practice to us. Yeah.
Sikha,
Thank
can
you
I
also
request you
delegates who
one
are
thing?
there.
Can I just
Yes.
request you? Dr. Naresh Thakkar, sir, madam, just troubling you. Just a last question.
No,
Dr.
absolutely
Naresh
no
Thakkar
problem.
wants to know, but how to imagine and diagnose vertical talus by 4 months?
So it will be the reverse deformity of a clubfoot. So if the clubfoot is looking like this, it's a rocker bottom. So it's a boat-shaped foot. So you won't need to imagine, it will show up right in front of you.
Yeah,
But those
you.
children are syndromic. They are generally with spina bifida or arthrogryposis. So unlikely that somebody as senior as you would miss it if it really comes.
Yeah. Sikha, sorry for that interruption.
No issue.
Yeah, thank you.
So we should cover as many questions as possible. That's the whole purpose of doing a Webflix one-to-one discussion. Anyways, thank you also the delegates to be here with us at this hour. And before we wind up, just a few announcements that we have in September. 15th of September, we have a very focused communication workshop, which is going to be with limited registrations at the Sion office of IIP Mumbai. So kindly register for the same. 22nd September, we have another CME on ECGs and arrhythmias at Fortis Hospital, Mulund. And next month, of course, the Webflix series we plan for pediatric surgery. So we'll, of course, put up the dates and flyers very soon. And plus, very importantly, please block your date for our annual conference, the Navi MBCon conference that is going to be held on end of November. So 30th of November and 1st of December. So kindly stay tuned with the messages in the zonal groups and kindly block your dates for the same.
There's one more. So on the 20th of September, the month of September is the Childhood Cancer Awareness Month. So on the 20th of September, we are having a workshop, which is primarily going to be focused for parents of children affected with cancer. And it's a holistic workshop where the psychological aspects, help regarding receiving donations and getting their therapies done, vaccinations in them, diet in cancer affected patients. So there are good, interesting topics that are going to be covered. It's going to be at Sign IP office in between 2:30 and 4:30. So if you have patients or if you're visiting hospitals or specialized OPDs where there are patients with cancer, then this message is going to reflect in the groups. Do let them know, and they should just give their names at the office numbers and join the workshop.
Thank you.
Thank you so much. Thank you,
for being
Rishita
such
ma'am.
an engaged audience. Thank you and good
Thank you, madam.
Thank you, madam. Thank you so much.